Hi friends, today's video is about Weber syndrome. So just before going into the topic, we shall discuss something about the midbrain. So in the dorsal surface of the midbrain, we have four rounded elevations, two superior and two inferior colliculi. This section is at the level of superior colliculus. So in the internal features, we have the cerebral aqueduct, which is covered by the periaqueductal gray. So a transverse plane passing through the cerebral aqueduct divides the midbrain into a small posterior part called the tectum and a large anterior part. The large anterior part is again divided into right and left halves by a vertical plane. This is called cerebral peduncle. The cerebral peduncle is again divided into three parts from dorsal to ventral, the tegmentum, then the substantia nigra and the crus cerebri. The crus cerebri mainly contains the major descending tracts, that is the fibers coming from the cortex to the spinal cord. Then the structure of the tectum and tegmentum vary in different parts of the midbrain. So now going into the Weber syndrome. This syndrome is produced by a vascular lesion in the basal region of the cerebral peduncle due to the occlusion of a branch of the posterior cerebral artery. So the midbrain is supplied by the basilar artery through its posterior cerebral and superior cerebellar arteries and some branches from the posterior communicating as well as the anterior choroid arteries. So in Weber syndrome, the posterior cerebral artery is going for occlusion. So we are experiencing a vascular lesion in the basal region of the cerebral peduncle. So which part of the midbrain is affected? This part of the midbrain is affected. So in Weber syndrome, we have to mention two important features. One is the contralateral hemiplegia due to the involvement of the corticospinal tract. The other is the ipsilateral lateral squint due to the involvement of the oculomotor nerve. The corticospinal tract is otherwise called the pyramidal tract. As of the name suggests, the fibers come from the cortex, that itself from the motor cortex, and ends in the spinal cord. Now, why it is called pyramidal tract? This is because these fibers at the level of medullary pyramid will decussate towards the opposite side. Okay, and these fibers are involved in majority of the voluntary movements. Now, why it is contralateral? This is because the lesion is happening before the decussation in the medulla. Did you understand? I will make it more clear. Suppose this is the midbrain. Okay, then this is the medullary pyramid. Now I am drawing the midline. Below we have the spinal cord. The fibers are coming from the cortex. Okay, above from the cortex, passing through the internal capsule, the midbrain, all the brainstem structures, and reaching the medullary pyramid. About 80% of the fibers will decussate towards the opposite side. Okay, and then descends down as the lateral corticospinal tract and ends in the spinal cord. So where we have lesion? We are having lesion in the midbrain. So happening before the decussation. So the fibers are crossing to the contralateral side to innervate the structures over there. That is why we are experiencing contralateral hemiplegia, the vascular lesion happening on one side but experiencing the hemiplegia on the opposite side. That is why contralateral hemiplegia. Suppose in some other syndromes we are having lesion somewhere over here, then we will experience ipsilateral hemiplegia. Okay, hope you understood. So the second feature is the ipsilateral lateral squint due to the paralysis of the third nerve. So the third nerve is called the oculomotor nerve. It supplies almost all muscles of the eye except two, that is the lateral rectus L6 and the superior oblique SO4. This is because superior oblique is supplied by the trochlear nerve and the lateral rectus by the abducens nerve. So when all other muscles go for paralysis, these two muscles predominate. So their actions also predominate. The lateral rectus causing the abduction of the eye, superior oblique causes the abduction, depression and intorsion. So basically, which affect majority? So if I am drawing my nose, my eyes, my eye will always be abducted. That is, it points towards the lateral side, right? That's why we are saying lateral squint. So the two important features, contralateral hemiplegia due to the involvement of the corticospinal fibers, and it is contralateral because it occurs before the decussation in the medulla. Then ipsilateral lateral squint due to the paralysis of the third nerve. That is about the Weber syndrome. Hope you understood, and thanks for watching.